to the final three round of the year and also to my final day in residency. Today I will be presenting. Before starting, I would like to introduce Professor Mildred Cho from the Center of Biomedical Ethics, who is joining us tonight for this discussion. She was a wonderful advisor during the past couple of weeks on how to structure this talk, and she gave me great feedback. Hi, Dr. Deckler.
Hey, how are you, Rami?
Good, how are you? I have no financial interest to disclose. However, I must disclose that Dr. Wong took me for a glass of wine that was very generous prior to this talk. And that might influence my talk tonight. Here are the objectives for the talk. We will first very briefly review the basic concept of bioethics, then we will talk about surgical ethics, which is a new subdiscipline of bioethics. And then finally, we'll talk about bioethical issues within otolaryngology. This is my own personal background within bioethics. Prior to joining the medical world, I did quite a bit of work in bioethics. I spent several summers, first at the Yale Interdisciplinary Center for Bioethics, where I studied research ethics. Then at Stanford, I was in the Center of Biomedical Ethics with Sandra Lee, and I studied pharmacogenomics and racial biases. And finally, just prior to medical school, I studied the ethical issues within public health with the Nuffield Council on Bioethics in London. I want to thank Professor Cho and also Professor Magnus for providing me with advice during the preparation of this talk. I also want to remind the residents that Stanford is the home base of the American the field, and that you have access to excellent faculty who can direct some of your work. So bioethics goes back to many, many centuries ago. We all know about the Hippocratic Oath. Some people talk about the Hammurabi Code as the first code of medical ethics that goes back to 1750 BC. Bioethics, as we know it nowadays, is a discipline that unfortunately was born in some dramatic and urgent historical events. In 1947, the Nuremberg Code was born out of the trial of Nazi doctors that were involved in experimentation on human beings. Jenny gave us a talk on that. In 1964, the Declaration of Helsinki by the World Medical Association provided with further guidance on what constituted ethical experimentation on humans. And then, unfortunately, in the US, up to 1972, the Tuskegee study studied the natural history of syphilis in rural African American men, and basically led to the Bellman's report, which provides the ethical basis for a lot of in the United States. Thank you, Dr. Wong.
The best way to go.
I use the term lubricated.
So we are all familiar with the four Prima Facie principles of bioethics. Those were written for the first time by Beauchamp and Childress in 1978. And since then, these two authors have been advocates for these four basic principles. The principle of autonomy is the principle of basically self-rule that we provide individuals who have the capacity of making decisions for themselves through reason. Non-maleficence is the well-known principle of do no harm. Beneficence is trying to do the most benefit to individuals as they're going through therapy. And justice is the principle of fair allocation of resources to individuals within health services. There are a multiplicity of paradigms within bioethics, and I will not go into the details of that. Obviously, bioethics is a very rich field with a lot of interesting dilemmas that merit further study. Principism is basically the view that the four principles that I just mentioned are the core principles of bioethics. The ontology is that there is the idea that there are some basic rules that cannot be infringed. That goes back to Immanuel Kant, for those who have studied philosophy, who saw the categorical imperative, where we have to see individuals as ends in themselves, not means to an end, and basically the rules that come out of that. Utilitarianism is a very popular philosophy of ethics that goes back to trying to do the maximal good to the most number of people. You may be familiar with Peter Singer. Virtue ethics is basically looking at what would the most virtuous person do in this particular situation, and casual-determinist ethics basically look at the context of decision making for ethical dilemmas. So since the beginnings of bioethics, at the beginning of during the last century, we've seen the generation of many sub-disciplines, including genetics, nanoethics, and most recently, surgical ethics. Why the field of surgical ethics? Well, there was this article that came out in 1995 that basically looked at how often ethical issues were mentioned in surgical literature versus medical literature, and we found that the surgical literature had a very poor display of ethical discussion compared to the medical discipline. In fact, it was 0.5% of articles that mentioned anything on ethical issues, which was 4 times less than in the medical literature. Since then, however, there have been numerous publications within surgical ethics, including these 3 books. And there is even a fellowship at the University of Chicago that looks at, that focuses just on surgical ethics. So what sets surgical ethics apart? Surgical ethics is first and foremost focused on the ethical behavior of the surgeon. So that really concerns all of us. But it also looks at the unique situations that surgeons will confront through their discipline. There's this really beautiful text that I recommend that all of you read by Miles Little, who is a surgeon and bioethicist at the University of Sydney, who basically has come up with these five roots of ethics within surgery. The first root being rescue. As surgeons, we're imbued with the unique power to incise patients, but also to endorse their trust as we're infecting them with a very invasive procedure. There's also the root of proximity. We have a very intimate relationship with our patients. In fact, they will never see what we see through this intimate relationship. And through this invasive procedure, we also inflict them with a significant ordeal, not only before the surgery, but also obviously during the surgery and after the surgery. They find themselves with a scar, which is a reminder of their mortality, and that is the aftermath of surgery. And then finally, as surgeons, we must be present, not only as we're advised patients either to their operation. During the surgery, obviously, we're very active participants, but also following the surgery, we're forever responsible for the outcomes of these patients. So there are some specific professional virtues of surgeons that have been put forth. One is that surgeons act as patients' fiduciary. That means that no matter what, the patient's benefit and health interests come before your own interest as a surgeon. Therefore, if the patient has HIV or Hep C, you're still obligated to provide them with surgical care. Obviously, integrity and compassion are critical professional virtues, but also the idea of self-effacement. We are given a special power over these individuals, and we must not let our ego interfere with the best interest of these patients. The idea of self-sacrifice, we all know about the fatigue that surgeons go through, not only through training, but also through career development. And finally, the critical difference between surgeons and medical physician is that we are active participants during the treatment process of patients, whereas medical physician will give a script, for instance, and may have a more passive role through that process. Some authors talk about a surgical contract, where that's a more legal term, legal perspective on how we interact with patients, where the patient basically entrusts us with with the power of doing a very invasive and potentially risky procedure on them. So what are the features of an ethical situation? An ethical situation arises when we may have two options or more than two options where the rights and wrongs within each option are pretty equivalent, or where there might be moral imperatives that are conflicting. This a pretty well-served example of that is a patient who might be refusing a life-saving procedure. So you want to respect the patient's autonomy, but at the same time you are torn because you do not want to do harm and you want to do the most good for this patient. An issue within surgery is that we tend to think in binary terms, either to operate or not to operate. But within ethics, we deal with degrees of values and maybe more subtle nuances that drive decision making. There are multiple unique situations that lead to ethical challenges within surgery. One is the surgical informed consent, where we inform patients of the risks and benefits of the procedure, yet when we are in the operating room, we have no longer an opportunity to discuss with them any decision-making that we may be taking during the surgery. Issues with industry relationship, a lot of us use devices. Outcomes reporting is extremely critical for surgeons, as we are mandated now to report all complications and mortalities. There are complications, also difficulties with surgical research, including sham surgery, which we have talked about in the past. And professionalism in the operating room is also unique to surgeons. DNR, DNI, and the perioperative period, which we will talk about shortly. And finally, fatigue and patient care, at which point does that interfere with our decision making. Ethics education in surgery is actually, unfortunately, poorly represented. We do not have the data for otolaryngology, but within general surgery, we know that 85% of program directors want to have an ethical component to the teaching. However, only 24% of programs around the country have two or more activities through residence training. Here are some steps in approaching a dilemma an ethical dilemma in surgery. First, you want to get the facts right. So you want to know the medical indication to your surgery, but also know what the alternatives are and the risks and benefits of each of the options. We know that from doing informed consent pretty much every day. But with presenting the medical facts to the patient, we must be able to also assess whether the patient has capacity to understand what we're presenting to them, and whether their preferences are also being represented. The patient may not want to undergo a very invasive procedure that affects their quality of life. Finally, there are contextual features that may affect the decision-making regarding the surgery. For instance, the hospital may have a certain agenda for resource allocation and may want certain types of surgeries to be performed or not be performed. Does anyone know John Conley here? Okay. All right. Would you like to say something about
a wonderful human being, a wonderful surgeon, just a wonderful person, great educator.
Dr. Conley was head and neck surgeon at Columbia University, and he was very dedicated to professionalism and ethics. In fact, he created an ethics fellowship for medical students, and up to this day, medical students can submit their articles to the AMA and be sponsored by his fellowship. He also wrote the first piece on the ethics of otolaryngology, and maybe I'll have Brian. Can you read me the quote?
Sure. Ethics in surgery of the head and neck have developed a special poignancy because of the astounding advances in medical science and technology, with their application to this exposed area of the body that is so intimately related to aesthetics and physiology.
There is a yearly John Conley lecture that occurs at the Academy, and oftentimes we have extremely interesting speaker come and talk. Last year it was, I believe, a As I was preparing for this talk, I was in touch with Dr. Andrew Schumann, or Andy. Andy is actually the only otolaryngologist who is formally trained in bioethics. While he was doing his fellowship at Memorial Sloan Kettering in head and neck surgery, he spent also a year at Cornell. And he has been a pretty prolific writer in bioethics within our field. And this goes to show that you do not necessarily need to be in the biosciences. You can also do some very interesting work in the humanities and get published within our field. One of the papers that Andy produced in 2012 was basically the implementation of an ethics grand rounds in his department at the University of Michigan. And he formatted his grand rounds in such a way that they resembled the M&M. And he requested that residents provide him with cases where they felt that there was an ethical issues, and he would use that as a sounding board to discuss some of the ethical principles that we must keep in mind as we perform the job. I will now go into some well-known ethical issues within otolaryngology, and I just want to thank the residents who gave me some cases. I used only one of them. But I think it embodies some of the issues that all of you guys had provided. I think a lot of us are familiar with the ethical implications or the ethical conflicts that arose with the advent of cochlear implantation. As you may know, the deaf community who uses the American Sign Language for communication has been extremely resistant to the advent of this technology. They have talked about cochlear implants as child abuse or cultural genocide. And that is even with the knowledge that the cognitive impact of cochlear implants are significant for patients, and with the fact that those patients tend to do very well, much better socioeconomically than patients who are deaf. Furthermore, the deaf community tends to see their hearing impairments as not as a disability, but as a great opportunity to be part of this unique culture where they find a lot of meaning. This is also, in the setting of them being the greatest users of the American Disability Act, and so there's still a lot of conflict and debate around this idea. Actually, Professor Cho mentioned that autism nowadays is also kind of encountering this similar issue with the idea of autistic children or autistic individuals wanting to be described as neuroatypical rather than autistic. Sorry.
Yeah, well, I think that there have been some publications actually in scientific magazines by people who are scientists who actually have autism spectrum disorder and were lobbying for it to not be considered necessarily in all cases a disorder. Clearly, it's a large spectrum. So I think part of this is coming from a sense that medicine tends to categorize, and sometimes there are lumpers and there are splitters, and so I think part of this is coming from a desire to have a more nuanced approach to how medicine categorizes individuals.
Does anyone know who this is?
Sure.
Okay. Roger Liebert's passed away now 3 quarters back. Unfortunately, he had multiple head and neck malignancies and had a total mental. And this brings me to the next topic, which is head and neck surgery and quality of life. In otolaryngology, we're very privileged to treat the head and neck, and as you know, the face is a part of the body that we often associate with identity. Not only the face, but also the voice and the ability to hearing. Obviously, as patients are getting consented for very invasive and potentially disfiguring head and neck surgery, we need to be able to discuss with them how that might affect them as individual or part of the community. Head and neck patients are also a very challenging cohort. They tend to have more psychosocial difficulties, including substance abuse. It is therefore very important to take the time and involve social workers and only family members in making decisions that might be altering the patient's mind. As you may also know, there is a new legislation within California that was passed just last fall, the end-of-life option, which gives the chance to patients to choose to terminate their life if they have a terminal disease. And that might actually be something that we need to keep in mind as we're treating these patients with head and neck cancers. Professor, do you have any ethics consults right now regarding this end-of-life option act?
I haven't personally, but I know that the ethics committee has been very busy, and the hospital has been very busy with both trying to assess what the clinicians' sort of positions are on this in order to determine what the best hospital position and policies. And it has been very, I don't know if any of you have been involved in any of those discussions. It's been extremely polarized.
Another famous ethical dilemma within otolaryngology is that of the face transplant. The first face transplant was performed in 2005 in France, and prior to that, if you look at the ethics literature, none of the bioethicists felt that the face transplants were legitimate. Actually, 0% of ethical articles that were written around that time felt that it was a safe procedure and felt that there were a lot of issues surrounding identity. But interestingly, after 2005, things changed significantly as we got to observe that the recipient of the face transplant actually looks nothing like the donor, and they subjectively also do not feel like their identity has been modified via the face transplant. Since 2005, the concerns are no longer with the ethical issues of the face transplant itself. There are now some more nuanced discussions about the ethics of face transplants in patients who are blind or in pediatric patients. This is also a very common and I think well-known case among residents and attending. The ethics of treating patients who are hemorrhaging or potentially will be hemorrhaging and are Jehovah Witnesses. This is a particularly difficult ethical issue when it comes to the care of children. Jehovah Witnesses are actually a fairly large proportion of the adult U.S. population, and though it is a very young religion, it has flourished through the country. The ban on transfusion goes back to 1945, when the interpretation of the translation of the Bible by the Jehovah Witnesses was that eating blood or transfusion was the equivalent to eating blood. However, one should know that giving blood to a Jehovah Witness does not condemn them to eternal does not lead them to eternal condemnation, and it is not considered a sin, and they can actually repent, which is not something that I knew before. Dr. Wong, actually, you told me an interesting story about having to consult the ethics committee for the care of a patient, an adolescent patient. I was wondering if you could tell the story too.
So I saw a 17-year-old adolescent with nosebleeds and a nasal mass, male, clearly a JNA and huge, and was affecting his speech, breathing, just clearly this needed to come out. And he said that he was Jehovah's Witness, and so were his parents, and they had come with an advocate, so they were very well versed in all the medical care issues. associated with being a Jehovah's Witness. And so I told him, and I was pretty sure that at his age, when he was under general anesthesia, he would be awarded the state. And so that's when I called the ethics council, because I needed the parents, if they were going to sign consent, that they would be turning over the authority to the state, which means me, to transfuse him if we got into a situation where he would need blood. And so that was the case, and they did not want that, and he did not want that. So it was very helpful to have the ethics consultant then. And so what we ended up doing was, they said, well, the only way that you can really have control over what you want me to do is to be 18. And so we actually waited for the better part of a year, and we planned the surgery a couple weeks after his 18th birthday. And that's what he wanted, and that's what the parents wanted. He did fine, but it was an interesting negotiation around minors or people who can't give consent and the coexisting issues associated with it.
Did you need transfusion?
No. But I was there, obviously there's
But
no
you
way I was
didn't
gonna,
know that.
oh, there's no way I was gonna tell him that, as acting on his behalf, that I wouldn't allow him to die if I was the one that was responsible. So sort it all out.
Question,
So-
why would he be awarded the state if he's under general anesthesia? Just curious, I've never heard of that before.
I had looked into that. I don't know why, but in the state of California, that was. I mean, I looked into the sort of legal precedents for it, and I think that is the issue of under anesthesia they become awarded the state, and then
And this is only for Jehovah's Witnesses.
I'm actually not sure. Only
No,
for
is this
Jehovah's
only for Jehovah's Witnesses or any minor that goes
I
under
think it's a-
anesthesia?
A
So,
general principle to intervene on behalf of the life of a minor child.
Okay.
right, so in the children's hospital, we will routinely go to the court and get custody when we have to do it. I mean, it's actually pretty common. And the difference in your case is that you had an adolescent with opinions, you know, who is really very close to being able to say what they want. And that's a different negotiation compared to the newborn or the 2-year-old where they don't have a say in the matter.
Does that give you the option to go ahead and do what you think is necessary if the parents object, or is that different?
No, that's correct. So the children's hospital position is that if it's life-threatening, we will transfuse, and we tell them right up front, we will go to the court to do that.
Right.
And we've even had like cardiac kids where, you know, they just routinely, we go to the court, we get custody, and then we give it back, and then they get custody again, then we give it back. I mean, it's almost ludicrous at times. But
Wow.
Yeah, that's exactly right. So you can, if the parents are adamant that no blood transfusion should be given to their child, and you're in an urgent situation, then you can go ahead and give the blood transfusion and retroactively go through the legal mechanism. So thank you for the discussion. You covered all the points. So
Sorry.
I have 2 case studies. The first case study is actually coming from an M&M that we discussed in the winter time. Adrian, thank you for sharing the slides with me. I was wondering if you could just go ahead and present the patient since you remember her well and those are your slides.
This was an elderly woman with a metastatic renal cell carcinoma with gross disease all over her neck, including her thyroid. And she was regularly coming into the ED down at Santa Clara Valley with stridor and shortness of breath that would typically resolve with some steroids, or she would usually be admitted to the ICU for a day or 2 for recovery. And each and every time we would have a discussion with her and her extended family, who was quite present, about tracheostomy and benefits of doing it and all the risks involved. Very thorough discussion. And each and every time, it just was not part of her clinical care. She had this widely metastatic disease, and if she was going to go from nurse to killer, she was very much, I guess, okay with that. Certain lines of care. Something or other happened. New family members came into the loop, and very adamant that she sort of pursue tracheostomy or pursue other options, maybe thyroidectomy or section or whatnot. She was seen kind of to get a second opinion, and ultimately did have a trach placed. She was then transferred back to Santa Clara Valley for social or insurance reasons to work on a position for her. She was transferred directly to the medicine service there from the ENT service here to medicine down there. We didn't necessarily know about her presence at the time until we sort of got a call in the middle of the night that she was having significant sentinel bleed from her trach. I don't know exactly how many.
It was within 2-3 weeks of the surgery.
Yeah, that sounds right. And, again, she, by the time we actually arrived, she had a pretty scary night, including pulselessness and required CPR, which initially was not at all. She was DNR'd.
DNI.
Absolutely not part of her goals, but that was rapidly reversed at the bedside at sort of family or her daughter's request. So the co-team and anesthesia sort of they proceeded and they resuscitated her. We were on call from home, so by the time they got there, she regained a pulse. And her bleeding has stopped, most likely just because she's been pulseless for a while. And ultimately, she never really regained significant neurologic status.
And the care was withdrawn the following day. So obviously a lot of issues with this case, and here are some questions that we'll go over right now. This session, part of the session is going to be interactive, so I'll be asking questions to the audience. So is there an automatic perioperative suspension of DNR/DNI? We often run into this issue with patients who require a tracheostomy, are in the ICU, and we do not have a rapport with the patient and we're asked to perform a tracheostomy. The prognosis of the patient may be very poor, and our main concern is getting a mortality outcome added to our name. So is there such a thing as automatic perioperative suspension of DNR/DNI?
I would think that if you got consent for the procedure, you would get included in that consent to intubate and maintain them through the procedure, that it would reinstate this procedure.
That's what I thought, and actually this is incorrect. So prior to taking the patient to the operating room, you must ascertain with the family that they're okay, or the surrogate, if it's not the family members, that the patient might be okay with the suspension of the DNR/DNI. And it might be the case that they're not. So then, how do we identify the surrogates when there are no advance directive for a patient? We ask the parents, the partner, the children, or is it up to us to decide who will be the surrogate?
I think the partner has precedence over the, well, if it's an adult, the partner has precedence over the parents, and the parents have precedence over children. Is that correct?
That's actually incorrect.
Okay.
It is actually up to the treating physician to determine who is the appropriate surrogate. So in this situation, we knew the patient did not want any invasive procedure. And it would have been fair for us as a treating team to request an ethical consult and to bypass the surrogate, to bypass the family and request another surrogate for this patient. You can get the social worker involved in determining another candidate for surrogacy. This is true within Stanford and most of the hospitals around here. It is not true at the VA, because at the VA it is considered federal government space, and next of kin will be chosen. It is also interesting to know that surrogates do not always make the decision that coincides with what the patient may want. It's only they make the correct decision in about 2/3 of the time. So there are many ways that we can identify the best person for surrogate when we don't think the family members are the best decision makers, and these are some of the features. And what do we do if we have a patient who is lacking capacity and does not have a surrogate? in emergency situations, you don't even need a consent. You just do whatever needs to be done. For routine care, such as feeding, basic medication, you do not need to get consent. You can just proceed with the routine care. How about in other cases, when you need to plan a surgery? Should you get a two-physician consent, or should you get an ethics consult?
It used to be two physician consent until ethics came into being.
That's correct. So two-physician consent, which is still something that we do as teams, treating teams in the hospital, is actually not sufficient. So you should request an ethics committee to weigh in and actually have a third party, that is a doctor who is not involved in the care of this patient, to weigh in and ensure that the surgery, the surgical intervention, is in the best interest of the patient and reflects their own values. For end-of-life decision, there is a subcommittee within the ethics committee that helps out with that and makes recommendations to achieve that. So there are many meanings to futility. There's a physiological meaning, meaning that your intervention may not lead to prolonged life. There is imminent demise, the idea that the patient is going to die no matter what within a brief time period, so your intervention is futile. Lethal condition is when the patient has a terminal disease and you may prolong their life for a short time period, but they're ultimately not going to survive. And quantitative meaning of futility is when the probability of your patient not surviving is very low. Qualitative futility is when the patient's quality of life might be significantly impaired by your intervention. So what is the legality of futile care in California? Well, you can actually decline as a treating team or as an individual physician to provide the care that you consider futile. In fact, if the patient or their family is insistent on a specific care, you feel that this care is not appropriate, you can tell the patient that you do not want to provide that care, but you give them a time period for them to try to transfer their care to another institution that could provide this care. As I understand from talking to David Magnus, and correct me if I'm wrong, at Stanford it's roughly 1 week. You give about a week to the family and the patient to try to transfer their care to another institution. But if they don't find any other institution, then you can proceed with concrete care. Is that correct? Which is not something that I knew. The ethics committee at Stanford is a rich group of individuals that come from all walks of life and all parts of the healthcare team. They actually do interdisciplinary runs with the ICU team on a daily basis, and they can be reached 24/7 through this pager number. What about surgeons and futility assessment? Well, it is our own responsibility as surgical physicians to decide whether the risks far outweigh the benefits of a specific intervention, and it is okay for us to say that we do not agree with performing a certain intervention without requesting the ethics committee's involvement. So multiple issues in the ethical situation we just described, including the determination of surrogacy, the suspension of the DNR-DNI. The surgery was futile in this case and in fact caused death, and there was no ethics consult.
Can I just stress that you covered this nicely, but this is much of the policy that was discussed is very peculiar to California, and California is a very peculiar state. So if you're going to practice in a different state and you're going to move there, you should check on what their state laws are, because California is a very odd duck. I mean, so for example, the example you gave is a much more common. There's usually a predetermined list for surrogacy, and you just tick off, you just go down the list until you get the first one, the first person who you can get a hold of. But California is
Thank you very much. Our second case is about surgical innovation, and as I'm going to UC Davis, I thought it would be nice to talk about a case from UC Davis. Some of you may know this patient. Brenda Jensen is actually well known for being the second recipient of a laryngeal transplant. Actually, it's more than a laryngeal transplant. It's a laryngeal tracheal transplant. She also got a thyroid and parathyroids from her donor. This was performed at UC Davis in 2011. Brenda was a 51-year-old female at the time. She had a renal and pancreatic transplant, and unfortunately, due to intubation injury, she got complete laryngeal stenosis and tracheal stenosis, and was not able to talk and was tracheostomy dependent. She was considered an ideal candidate for a laryngeal transplant, first of all because she was keen on undergoing the procedure, but also because she was already under immunosuppression. Another aspect of Brenda is that she did have a history of uterine cancer, but that had been treated many, many years ago. Had she had head and neck cancer, for instance, placing her on immunosuppression may have been ethically challenging. So Brenda was the second patient to get the laryngeal transplant. The first transplant had to actually be explanted after 14 years. It had been performed at the clinic. There were very uncertain benefits for her, and she was advised during a 2-year period that she may actually require total laryngectomy if her transplant did not survive, and the risk of that was fairly high. Interestingly, when laryngectomy patients are asked whether they would be willing to undergo a transplant, the average number of years of life that they're willing to lose for that is 1.2 years. So surgical innovation is actually a fascinating aspect of surgical ethics nowadays, and I really encourage you to look into that. One is, how do you perform really an informed consent when the patient is getting consented for a new surgical intervention when the risk and benefits are really questionable, and then when does surgical innovation actually become research? And interestingly, for surgical innovations as opposed to pharmaceutical innovations, there's very little oversight. In fact, every day in the operating room, we perform procedures slightly differently than we did the previous day. So what really determines what is innovation as opposed to a minor modification of an existing surgery? Reza, do you want to read this excerpt from the Helsinki Declaration?
Yeah. So Helsinki Declaration states that in the treatment of a patient where proven prophylactic, diagnostic, or therapeutic methods do not exist or have been ineffective, the physician, with informed consent from the patient, must be free to use unproven or new prophylactic, diagnostic, and therapeutic measures if in the physician's judgment it offers hope of saving lives, reestablishing health, or alleviating suffering. Paragraph 32.
So how is informed consent different in surgical innovation? So as mentioned earlier, there's a lot of uncertainty regarding immediate risk, but also regarding long-term risk. We have no idea, for instance, that 14 years later, the laryngeal transplant will have to be explanted. There's also a learning curve. As surgeons, we get better at our surgeries the more we do them. And if we're performing a surgery for the first time, we may not be as good as we will the 10th time. And obviously, there are also uncertain benefits compared to existing procedures. There's also an optimism bias in general in surgery among surgeons, but also among our patient population. We tend to be very enthusiastic about these innovations. So often it is recommended that when a new innovation is introduced, we offer a cooling off period for patients, roughly a month between the time we tell them about the new procedure and the time we perform the procedure, so they can really think, discuss the issues with their families, and have the time to withdraw themselves from the optimism of the surgeon. And then finally, some individuals recommend a consent advocate who would be a member of the treating team outside of surgery, who may not have a vested interest in performing the surgery. There are multiple levels of conflict of interest, including from the institution. If you get to do the first laryngeal transplant, for instance, you get a lot of advertising for your institution. So when does surgical innovation become research? Michael, do you want to read this?
Sure. A treatment involving a single patient can constitute research if there is a clear intent before treating the patient to use systematically collected data that would not ordinarily be collected in the course of clinical practice and reporting and publishing.
So really, the difference between surgical innovation or surgical treatment and research depends on intent. If your intent is your clinical practice or the treatment of the patient in front of you, then you are not performing research. However, if your goal is to produce generalizable knowledge, then you are performing research, and you should actually get an IRB approval before performing the surgery. Are there any oversights? Is there any oversights of innovative surgeries at Stanford? Yes, there is. Actually, the chief of staff and as well as the innovative care committee are involved in evaluating innovative procedures. And Professor Cho, I was wondering if you had personal experience being part of that committee.
Yeah. So actually, this committee came into being as a result of a consult that we had from about a surgical. Actually, there were more than one surgical cases that came up. And these came to our ethics committee, but not the hospital ethics committee. It came to our research ethics committee from the hospital ethics committee. And that was precisely because they, at the hospital ethics committee, was wondering whether this activity should actually be reviewed by the IRB. So they were themselves uncertain as to whether this was really treatment or research or something in between, and as a result of having these discussions about this case, it came to be decided that there should be a committee that sort of straddles this middle ground between research and treatment, and again, based on the sort of recognition that the intent usually starts out as either research or treatment and moves in the other direction, and it's not really clear when you sort of cross the line between, say, intent to provide treatment for a particular patient for their benefit and their benefit only, and when you start to add more patients where you're trying, maybe it's a new device or a new procedure or a technique, and you've done 5, and then you've done 20, and then you've done 50 patients, sometimes that crosses the line and now becomes research. And not only does it potentially become research that needs to be IRB approved, but it also may be that it is your obligation as a physician to actually change the nature of that activity from a fiduciary responsibility to the patient into a different kind of activity in which you are fulfilling what may be a new obligation to actually systematically evaluate the efficacy of what you are doing, as opposed to and to put into place research procedures and be systematic about data collection, as opposed to sort of after the fact, after you've done 50 cases, then retrospectively going back to analyze what you've done in a way that where it may not be possible to actually collect the data in a very systematic way, and in which biases may have been unwittingly introduced and cannot be removed afterwards.
Thank you very much.
Could I comment on that?
Yeah.
I mean, there's a fascinating divergence between introducing a new pharmaceutical, since the FDA was formed in the 1910s, where it's highly prospective with major studies and careful evaluation of therapeutic effect and complications. Innovative surgery is often individualistic by an individual surgeon who tries it out, often with incomplete or no informed consent. It really is extraordinarily different. The sentinel events leading to the formation of this committee were of that type, where an individual took a kind of a fringe theory about an important neurological disease and decided to do a series of poorly controlled, poorly consented experiments, basically, which in one case at least went terribly awry. And it led to a lot of concern. And it is interesting how little we surgeons, when we change something or try something, decide to go through some external review, discussion, looking together at planning it, maybe even setting up animal studies as might be done in some other area for like a medical implantable device. And people just try things in that way. The other thing I would say is there is always an inherent conflict of interest with the presumed fiduciary for the procedurist. And that is that you get paid when you operate and not when you don't. And that financial incentives, for anybody who's been around for a long time seeing how surgeons operate, there are certain surgeons who operate primarily for RVU, and there are certain surgeons who bias their decision for surgery in a way that does not maintain full fidelity to the fiduciary, to the patient. This is not rare, and this is something that we all have to guard against, that we're always thinking of the well-being of the patient and always choosing to operate or not to operate and which operation to do solely based on the best interest of the patient. And you know, sadly, financial incentives are powerful. Our system of economics is built on that, and surgeons are humans and live within the world of the economic necessities of their mortgage and their bills and their practice expenses. So I think we all really have to be conscious of it, be aware that we have that inherent bias, and that to fight against it coming into play in our decision making.
Thank you very much, Dr. Jackler. So we're close to an end. I just wanted to make sure that all of you in the room knew about the need to actually consult the Chief of Staff and the Innovative Care Committee if you're coming up with a new, radically new surgery. You actually need to get the approval of the institution, and there's a specific document that tells you what steps to take. You first write a letter to the Vice Chief of Staff.
Who's Ed Damros, by the way?
Yes, that's correct. There might be a bias there.
No, I don't think so. He would know too much.
And then, if appropriate, the Vice Chief of Staff might want your case to be reviewed by the Innovative Care Review Committee, and then a decision will be made whether you can go ahead with your innovation or not. And as we talked about, when you do more than one case of the same procedure, and you feel that the sort of information you're getting will become generalizable knowledge that is important for other patients in your institution or outside, then you may want to actually get an IRB on board and perform a prospective study in order to collect your data. We're at fault in surgery to do way too many retrospective research studies that are poor quality, and if you really want to change the future of your patients, you may want to consider doing some robust research, especially if you're introducing an innovation. So that will be the last comment of the evening. Thank you very much. I had a wonderful time. Yeah?
Excellent.